Josie?
Yes, yes, sir. Yes, ma'am. Can you see, ma'am? Can you see the?
Yeah, you introduce yourself and start.
Ma'am, can you see the PPT, ma'am?
Yeah.
Yes, yes.
Okay. Good evening, respected teachers. I am Josity Kosip, plastic surgery resident from Trivandrum Medical College. Today I am presenting two cases, spotters. This is my first spotter. Here, this is a photo of a left hand of the child. It shows an excessive overgrowth and elongation of the left middle finger with an ulnar angulation and also a dorsal deviation of the middle finger. There is also splaying of the fingers. There is a mild enlargement of the left index finger and the left thumb, and also the radial aspect of the palm.
I'm losing audio again.
No, I think all those who are not speaking, can you please switch off your audio? Somebody's audio is coming in between, that's why.
Hari, can you hear? I can't hear.
Yeah, we can hear there is disturbance. So kindly switch off your microphone. All those who are listening, please switch off your microphone.
Either I have internet problems or Dr. Koshi has internet problems.
Yeah, continue, Dr. Koshi.
Can you hear me now? Yes.
Yes.
Okay. So it shows an excessive overgrowth and elongation of the middle finger with an ulnar angulation, along with the dorsal deviation of the middle finger. There is a splaying of the fingers. There is mild enlargement of the index and thumb, and also the radial side of the palm. There is a dorsal picture also showing the hyperextension of the middle finger and the enlarged nail also.
I'm sorry, I can't hear anything.
Keep your microphone little away from your this thing and speak. Or are you holding the mic in your hand? That's some echo. That's why there's difficulty.
Is it audible now, sir?
Yes. Speak slowly and little away from the. Yes. No, he's not speaking now.
So
yeah.
No, sir. Sorry. So these are the two pictures given to me, sir. And also there is an X-ray.
Yeah, please put the X-ray now.
Can you see the X-ray now?
Yes.
Okay. Here only the middle finger is properly seen, sir. X-ray of the middle finger is properly. The rest of the fingers are in a flexed position. So here there is a overgrowth of the phalanx of the middle finger.
Hari, I think you should lead the questions because I can't hear anything.
Okay. Yes.
So no further detail. Since no further details are given to me, sir, because this is a spotter.
Yes. Tell what it is.
Okay.
So
diagnosis, doctor.
My diagnosis will be a macrodactyly of the radial 3 fingers, mainly involving the middle finger.
Why radial 3? Which is the third finger? Go back to the photo.
The thumb also is mildly enlarged.
Next picture.
Mildly enlarged.
The dorsal view.
This can you see, sir?
Yes.
I have put that picture.
Dorsal view we have not seen. We are seeing the palmar view.
Yeah, go to the next.
Show the other picture.
My screen is showing the dorsal view, sir. Sorry.
Yeah, there is the dorsal view.
Please put the dorsal picture, please.
Can you see now, sir?
No.
It is the dorsal view.
No, not yet.
Okay, let's leave the other two fingers. Let us talk of this one. What is your diagnosis?
It's so this is a macrodactyly of the middle finger, sir. Macrodactyly of the middle finger.
Yeah. And what are the causes of macrodactyly?
Sir, macrodactyly, differential diagnosis of the macrodactyly is vascular malformations, lymphedema, soft tissue or bony tumors. So there are many types of macrodactyly. According to Flat's classification, type 1 is gigantism associated with the lipofibromatosis, that is enlarged nerves with infiltrated fat. The second type is gigantism associated with neurofibromatosis, that is occurs in conjunction with the plexiform form of neurofibromatosis. And the third type is gigantism and associated with the hyperostosis, that is osteochondral periapicular masses will be there, in which there will be nodular masses around the joint, and the finger will be stiff. And the fourth type is added by Upton, which shows the gigantism with hemihypertrophy.
So this is which type you think?
This is type 1, sir. Type 1 gigantism and lipofibromatosis, involving mainly the medial nerve territory, sir.
Actually, it is this is my patient. Actually, it is nerve-oriented macrodactyly. But that you can't tell from outside. I'll give you that. Actually, it is caused by the nerve. This particular case.
Okay, sir. Okay. Okay, sir.
So, unfortunately, the marking is giving it away. But what treatment will you do?
Sir, first of all, this middle finger most probably is having a progressive macrodactyly, in which the growth is disproportionate compared to the other finger, and it is.
Yes,
Hello.
sir. Yeah, we can hear you.
Hello, sir.
Yes, yes.
So the middle finger has a progressive
So what will you
macrodactyly. First of all, I will investigate the child to rule out any associated anomalies. Then I will.
Right. What anomalies you are expecting with macrodactyly? Is it macrodactyly usually syndromic or non-syndromic?
Mostly it is 90% is sporadic, sir. 90% of the macrodactyly is sporadic.
Correct.
So,
very good.
If it is associated with the neurofibromatosis or any other syndromes like a Klippel-Trenaunay or Park's vascular malformation syndromes, I will do a proper workup of the child. After ruling out systemic involvement, only then I will take a X-ray of the hand. Also, in this case,
Yeah, X-ray is there already taken.
Okay, in this case, because the nerve involvement is common, so I will take an USG or a MRI of the hand also to rule out any proximal thickening of the nerve. The chances of nerve compression is more in the carpal tunnel, so I have to rule out the thickening of the median nerve proximally. Then after ruling out that, we'll expect the treatment of the macrodactyly is complicated and it may need repeated surgeries. And in this case, the middle finger is overly grown and it will hinder with the activity of the other fingers. So the best option will be a ray amputation of the middle finger. Sir.
Okay. When you do ray amputation of the middle finger and you find the median nerve is very thick, will you do anything to the nerve proximal?
Proximally, I will release the carpal tunnel, sir.
Yes, so that is very important. So you need to ask one history is very important. Does the child cry often at night? So one of the things parents may say that child at the end of the day or at night may get up from sleep, just like an adult gets up from sleep from carpal tunnel. So carpal tunnel syndrome, the median nerve compression is one of the causes of child excessively crying when they get pain. They are not able to tell that pain is because of carpal tunnel release. Okay. Will you reconstruct? Yes. That is, sir.
Yeah, I seem to have got it back. Sorry, what was the question?
No. How will you address nerve in the median nerve? Because if you have done ray amputation and the nerve is very big.
So I lost you again.
Okay. So.
Sir, hello.
Yes.
So if I do a ray amputation, the median nerve itself, I will not do anything great, except that if I see a lot of fat infiltration in the nerve, I will remove some of it under high magnification. Or otherwise, I will not be very aggressive with the median nerve.
So if the child, of course, this is a spotter and this much is enough. If you tell the classification of macrodactyly, and in this case a ray
Yes, sir.
amputation, you are justified in what you told. Very rarely, the other option
Yes,
is if parents refuse, what will you do? Then you have to say there are various ways of killing it.
Yes, sir.
So soft tissue and then corrective osteotomy, and even we have just recently published a paper where you transfer the nail onto the proximal phalanx, because the proximal phalanx itself will be the size of the other fingers. So you need to really sort of amputate the finger at that level and then reshape it. So yes. Okay. Good. So next spotter.
Can go. Koshi?
Yes, sir. Yes, sir. My next spotter is here is a child with a bilateral ulnar polydactyly. Can you see the picture, sir? Sir.
Yes, we can see.
Yeah. Okay. So there is an ulnar polydactyly or postaxial polydactyly where there is an extra finger in the ulnar side. The ulnar digit is a little shorter compared to the fifth finger,
Right.
and also there is a deviation, abducted position, and increased web space. And it is left side. It is showing in out of cascade position. So here X-ray is not available, sir.
Any
so-
movement photo? Flexion photo is there? No.
No, sir. No, sir. Movement is also history is not also not available, sir.
I think yeah, that's it. Okay, so what will you do?
So
why do you think this child has come to? Because this child must be at least looking at the hand around 5-6 years. Age is there?
Yes, sir. Main problem.
Yes.
No, sir.
Main problem?
Main problem will be aesthetic problem, sir. Mostly the all fingers he or she may be able to flex, but the extra finger aesthetic is the main problem, sir, for these ulnar polydactyly patients.
Yes. Actually, this is it doesn't sort of though it is an extra digit. You need to see the X-ray, but this won't be like a classical
Yes,
case
sir.
in the exam where you need to polydactyly. Ulnar polydactyly will just be a short digit which you need to excise. The only things which you need to remember is, or okay, let me ask you, if you want to do a ray amputation of the little finger, okay, what will be the level of the amputation? Will you go right up to the base? Or
First, sir, I will do an X-ray whether it is arising from the metacarpal or the
Right.
carpal bone. There is an extra metacarpal is there.
right.
So, and while removing, the main thing is the attachment of the abductor digitae minimi and flexor digitae minimi. And if it is to the extra finger, I have to reconstruct it to the fifth finger, and also the ulnar collateral ligament also should be reconstructed. So I have to carefully raise the periosteum and the attachment of the these three structures from the proximal phalanx of the extra digit, and the distal attachment should be preserved, and the incision should be extended proximally to remove the extra if the extra metacarpal is present, and then I have to reconstruct the abductor digitae minimi and the flexor digitae minimi, also the ulnar collateral ligament to the medial aspect of the proximal phalanx of the base of the proximal phalanx of the fifth finger.
Yeah.
Then,
But in this case, I don't think all that will be needed. You just have to shorten it at the level of the base of the finger.
yes, sir.
And of course, the metacarpal we have to see in the X-ray. And even X-ray, if you try to remove the metacarpal, it will be more of scarring. So I think if you remove the extra digit and maybe shape the base along the hypothenar crease, just the base of the finger, that should be sufficient.
Okay, sir.
How do you differentiate? Okay, assuming not in this case, but just a question. How do you differentiate a thumb from a finger? If you have a 5-fingered hand, so what is a 5-finger hand? Versus what is the difference between the thumb and the finger?
the finger have 3 flanks.
Yeah,
And
so
there will be
correct. If the thumb also looks like a finger.
yes.
It has also got same number of.
Increased web space will be there between the index finger and the thumb.
So
And,
do you have an X-ray or you don't have X-ray? So basically, the difference between what is the difference in bone at this age between phalanx and metacarpal? That's a question. Simple question.
yeah, the epiphysis will be
okay.
in
Let
the,
me give you an correct. Epiphysis is
in the proximal part in the phalanx and the distal part in the metacarpal.
correct. So that is how you differentiate a thumb metacarpal from the other metacarpals. Okay, so you have to look for the epiphysis.
Yes, sir.
That's the way you have to differentiate. So you differentiate between a 5-finger hand and a thumb. Is that you need to look at the epiphysis.
Okay, sir.
So coming back to ulnar polydactyly, so what are the other things associated with to look?
There are syndromic ulnar polydactyly and non-syndromic ulnar polydactyly.
Yes. So usually what are the syndromic ulnar polydactyly?
Usually ulnar polydactyly may be associated with syndromes. Syndromes like a Smith-Lemel Opitz and Bardet-Biedl syndrome, trisomy 13.
Have you kept a book open in front of you?
No, sir. Elvis Grewald syndrome is also there. I don't know. Elvis Grewald.
Yeah, so more important is what Tate sir asked before, Poland syndrome and the simple syndrome. The chest wall and other deformities are more common with the ulnar polydactyly. And ulnar polydactyly also will have more commonly, even if you have ulnar club hand, and ulnar polydactyly will have chest wall deformities and other deformities. Very rarely they will be associated with cardiac deformities, cardiac anomalies. Yes. So that's a differentiating point you need to keep in mind.
Okay.
Yes, sir. GB, sir.
Before Dr. Hari, is it over?
Yes.
Hello.
Yeah, I can hear you.
Yes, sir.
Yeah, Dr. Hari, before we get the questions in the chat box from the residents,
yes.
I have a question for Professor Tate, sir. Sir is on the line, sir. You said that
no, your voice is not clear.
For radial club band, sir, or sir, hello, sir. Do you prefer Evans incision for all radial club band, Professor Tate, sir? His audio has got some problem. Hello.
I think he's not hearing you. Tate, sir.
Yeah. Tate, sir. Yes.
Yeah, I think his preference is to use Evans, David Evans.
Do you use Evans always, Dr. Hari? Like,
yes. Unless we have
because we have once we have distracted, I think we can straight away go with the Lamb's dorsal incision. No, you won't fall short of
most
skin.
of the time. Yeah, that's all. Evans is mainly required only if there is an extra bulge.
When there is no distraction.
Most of the cases are not without distraction because we see them late. So if there is a bulge on the other side, it is nice to adjust this up. So it depends on the excess skin available. If there is excess skin available,
if you distract, probably the skin also. Yeah.
Yes. You don't need that.
You don't need it.
I think we have lost Dr. Patel. Okay.
I think
Dr. GB sir wants to ask something. Sir.
Am I audible?
No, not audible, sir.
Hurry. Not audible?
Now audible, yes, sir.
Yeah, now you are audible. Now you are audible.
So, no, you are asking about the difference between the 5-fingered hand and little finger and a thumb.
Yes, sir.
The 5-fingered hand, the case of a thumb,
yes, sir.
The thumb will lie parallel to the rest of the fingers.
Yes, sir.
That's the most important point to say is the 5-fingered hand. The thumb will lie parallel to the rest of the fingers. There won't be any grip space. Am I clear?
Yes, sir. Yes, sir.
Yes.
Yes, sir.
Yes, sir. Now we can go for the questions in the chat box, Dr. Sandeep.
Yeah. Hello. Yeah. Actually, Dr. Harsh has one question. What is the point said about epiphysis for differentiating between a polydactyl finger and the thumb?
Pardon?
What is the point said about epiphysis for differentiating between a polydactyl finger and thumb?
No, that's what answer he said, that epiphysis of the metacarpal of the finger and the thumb are different. So the thumb epiphysis differentiates between the a finger and a thumb. So if there is a epiphysis matching the other fingers, that means it is a finger and not a thumb. So it's a 5-fingered hand. Maybe a picture will demonstrate. Let me see. Oh, to explain, you need to put an X-ray of the hand. 1 second. Yes, next, please.
Yeah. Next question is by Dr. Vamsidharan. Sir, if median nerve is enlarged, other than carpal tunnel release, is there anything to be done? I think that already Saty sir had actually mentioned.
Yes.
Sir has actually answered in the chat box. Nothing further need to be done.
No, there is other option. Dr. GB also has presented in Professor GB in his presentation. If you remember, he has presented that sometimes if it is too big and too gross, and then people have excised it or divided it and put a nerve graft to reduce the size. But that is, of course, mainly to if you are excising it and you are having something which is going distally. So for that part, you put a nerve graft. So that has been done.
Yeah. Yeah, and also I think there are studies showing that in case there is a neurofibromatosis, neurofibromatosis is one of the reasons for gigantism. You have to go up to the proximally up to the normal nerve and excise the rest of the things if you want to get a more long-standing result.
Yes.
Yeah, I think that's all the questions were there in the chat box.
That's all.
Yeah. Because I think almost all the questions that were in the chat box have already been answered by Saty sir. He has answered in the chat box itself. There are a lot of questions in the chat box. Yeah. Is there something? Yeah, I think we have through with all the questions. Is there something else that you want to talk to the students, Harry? How to actually approach a case of a congenital hand, something like that?
I think this is, so I will just, 1 second. So that's a good question. So what we have done is that we have created an SOP for congenital hand. I'll just run through it. I don't have it in my, so what you are supposed to read, number 1. So I think there is so much of literature available. So nowadays, I think you can read both Nelligan, Green, and of course, we have Adrian Flatt's textbook also. History taking, number 1. So first of all, most of them covered everything. The birth weight is one thing which you need to keep in mind. And the gravida of the mother, that is firstborn, secondborn. So that part also has to be kept in mind. Antenatal history is little more, other than consanguinity, everybody stressed on consanguinity. So that is important. But other than consanguinity, you have to be more particular about asking the exact history. So drugs, and if you ask drugs, then you need to know what are the drugs which causes congenital anomalies. Because some of the old drugs like have been restarted, and so you need to ask this thing. Gestational diabetes is one of the very important things which happens now. So you need to particularly ask whether mother had gestational diabetes. Type of delivery, birth weight is also very important because it also tells us about the birth weight and the other associated anomalies. Usually, if you have a cardiac anomaly, failure to thrive and other things will be there. Then neonatal history is very important. So you need to ask immediately after birth whether there was any ICU admission, any 2D echo or anything was done immediately after birth. because most of the time, if the child is born and in now most of the hospitals, and if they have a thumb anomaly, immediately the pediatrician and the neonatal would have done some investigation. So many of them will have that. Then you need to, of course, all the classifications you need to know. Developmental milestones are very important. Like there was the issue about psychometric, whether testing has to be done. If milestones are correct, so you need to know the milestones, and you also need to know the hand usage. So first you do a claw, you just hook, and then you opposition comes at 1 year of age. So all those milestones of the hand you need to know. Then clinical examination. First, you start with you need to undress the child fully, and from head to toe, you need to see. And also, usually, you have to ask many of them, if it is syndromic, they come with parents or grandparents who are also having it. So, it's also nice to examine them also, their hand also, if they come with that. Recording of all the anomalies from head to toe is very important. So, you need to record it correctly and get appropriate investigation. So, both blood test as well as the X-rays, the right views of the X-rays are very important. So you need to get all the X-rays done. And then comes what additional investigation you'll order. So of course, 2D echo and ultrasound is to rule out cardiac and abdominal, intra-abdominal issues. And main title in diagnosis, when you write, you need to write the main title of the diagnosis. So what exactly it is, what type of anomaly. So in radial club and what type, hypoplastic thumb, what type. So what type? Then you need to use what classification you have used. So if you have used IFSS classification, you need to write vessels or according to the IFSS classification or OMT classification. So what classification you are using should also come in your diagnosis. And of course, preoperative, you have to cover everything. So consenting of the parent, what exactly you need to consent. So that you need to know, because if you are discarding a finger, you need to tell what level it will go and what is the exact consent. Consent for taking skin grafts if you are taking, and also looking at the donor sites. So if you are taking a full thickness graft, or if you are taking something else from other part of the body, then you need to examine the donor site also. So these are the sort of 9 steps you need to do for any congenital hand. That is, sir.
Sir, Sir, you're able to hear us?
I think is.
Sir, you're able to hear us, sir?
No, I think again.
Yeah, I think sir is not able to hear us. I just put one
message.
Yeah, message.
Anything else presenters would like to ask? Dr. Litika, Dr. Koshi, in preparing or in?
Yeah, I must say that all 3 of them presented really well today. And I think we've had a great discussion also. And a lot of questions were there by other people also in the chat box. I think that is also answered. I think almost all the questions were answered immediately by sir in the chat box. Sir is not able to hear us. Okay.
Yes.
I think there must be some problem with this connectivity or something like that. Yeah. Anything further to ask, Dr. Radhakrishnan, Dr. Lakshmi? I think both of them. Yeah.
Anybody else in
Dr. Sandeep?
Yeah.
Dr. Sandeep? Yeah. Audio, I think Dr. Patesar's audio had a problem, I think. That's why probably he's not able to communicate, I think.
Yeah, correct. We're able to see, but unfortunately,
yeah, I think most of the things have been discussed. Any more questions in the chat box? I don't think so.
No. I checked it out.
Yeah.
There are no more questions.
Yeah. It was a very nice discussion actually by Professor Tatte sir, and who is always there to whenever we requesting for any classes. Same thing with Dr. Harivenkatamani also. Whenever we ask for any scientific discussion, he's always there to back us up. Thanks a lot for both of them for spending this quality time discussing all newer things, newer nuances, and smaller fine tidbits also. Thank you very much. Thanks a lot. Any other? Tatte sir, I think is back. I think. Sir. Hello. Hello.
Tatte, you are able to hear us, sir?
Sir, are you? Can you hear, sir? Tatte sir?
No, I don't think he's able to.
I think I will leave. Cannot hear at all. Tatte sir,
yes, I think so.
I think I will leave. Cannot hear at all.
Okay. Yeah. Okay. Yeah. So we thank everybody and residents for putting up a good presentation also. Thanks everyone. Stay safe and take care. Thank you.
Thank you, Dr. Hari.
Thank you, madam. Just answering one last question and then thanks a lot.
Thank you. Thank you, Dr. Hari. Thank you.
Yes.